So in the previous class, have you done the previous class? So pharmacokinetics have been started. So pharmacokinetics, there are mainly 4 stages: absorption, distribution, metabolism and elimination. So absorption and distribution has been done. Today we will discuss about the metabolism part. So when a drug comes to the body, so drug is basically an outside object. So it can be termed as xenobiotic. Okay. Xenobiotic. Xeno means outside of the body. That not belongs to our body. So xenobiotic, how a xenobiotic can be metabolized in our body is discussed in this metabolism or biotransformation chapter. So biotransformation means it is transformed, the drug, when it enters within our body after absorption and distribution to tissues, it should be transformed in such a way so that it can be easily eliminated from our body. So that is the main object. How the elimination can be done after some changes in their structure so that it will be more easily soluble in the water or vice versa. So that is the biotransformation or metabolism. So it means chemical alteration of the drug in the body, chemical alterations. Now it is commonly, the common notions is to render it non-polar lipid soluble compounds polar. So most of the drugs, those are non-polar, that is lipid soluble. Lipid soluble is needed because our drug have to be absorbed through the lipid bilayer. So if the drug is lipid soluble, that is easy to be absorbed. But after absorption, after distribution, it has to be eliminated from our body, and that needs, it should be some hydrophilic object. So becoming more hydrophilic ultimately helps a drug to eliminate easily from the body. So to make it polar, lipid insoluble means it becomes automatically water soluble, so that they are not reabsorbed in the renal tubules and are excreted. Most hydrophilic drugs like streptomycin, neostigmine, pancuronium, etc. are little biotransformed and are largely excreted unchanged. That means it is not such that every drug undergoes the similar type of biotransformation. Some drugs undergo very little biotransformation. Some drugs after biotransformation also converted to some active moieties, like that. Mechanisms which metabolize drug, essentially foreign substance, that is the xenobiotic, have developed to protect the body from ingested toxins. So it is the objective of the metabolism or biotransformation. Now where this biotransformation happens, the primary site is the liver. Liver is the primary site. Apart from this, kidney, intestine, lungs and plasma also play a role in biotransformation of drugs. Inactivation. So the biotransformation of drugs may lead to the following changes. The most common is the inactivation of the active moieties. So most drugs and their active metabolites are rendered inactive or less active. So the drugs becomes active after absorption, distribution. It is rendered inactive in biotransformation in most of the cases. Example, these are the example of the drugs that becomes inactivated by means of the biotransformation. Ibuprofen, which is basically a pain relieving drug. Paracetamol, you know about this. Lidocaine is a local anesthetic. Chloramphenicol, propranolol. So these are the different drugs that is inactivated by biotransformation. On the other hand, some drugs may develop some active metabolite from an active drug. So inactivation first, next development of the active metabolite from active drug. That is, the drug is active and the metabolite is also active. Okay. So many drugs have been found to be partially converted to one or more active metabolite. The effects are observed are the sum total of that due to the parent drug and its active metabolite. It happens. These are the examples. Many drugs where the metabolite is also active, and ultimately the action of the drug depends upon the total action of the drug and its metabolite. For example, morphine is converted to morphine 6-glucuronide by glucuronide conjugation, which is also active. Primidone is converted to phenobarbital. Both are active moieties. Digitoxin converted to digoxin. This is needed in the cardiac failure. Primidone, phenobarbital, morphine, these are the CNS drugs. Imipramine is converted to desipramine. Amitriptyline converted to nortriptyline. These are the tricyclic antidepressant group you will read about in the CNS chapter. Codeine is converted to morphine, again in the CNS drugs. Spironolactone is converted to candidione. Spironolactone is a diuretic drug. You will read about the diuretic chapter and also in the CVS. So these are the active moieties. These are formed from the active drugs. So this is the second type. Another is activation of the inactive drug. So inactive drug may become activated by means of the biotransformation also. And this inactive drug, when it is given to our body, this is known as the prodrug. So prodrug is activated in our body by means of the biotransformation. So few drugs are inactive as such and need conversion in the body to one or more active metabolite. So these drugs, when they are absorbed, when they are distributed, they are inactive. But after metabolism, they becomes active. So these inactive drugs, when they are given, this is known as the prodrug. So this is a common question, what is prodrug? This can be asked in your exam. So prodrug is basically inactive drug that is given in our body, that is absorbed and distributed, and then it is transformed by means of the biotransformation to some active drug. And active means it does some action on our body. So it acts on different types of the receptors. You will read about these receptors in the pharmacodynamics part. So pharmacokinetics means what the body does to the drug. Already you know. And after the pharmacokinetics, there occurs the pharmacodynamics. That is the how the drug changes, how the drug acts on different receptors and ultimately does different actions. So these are the active drugs. So the prodrug may offer advantage over the active form in being more stable. Why some products are used? Because some inactive drug that is given, that has to be passed through the intestine, that has to be passed through the stomach. So some drugs may become destroyed through this when it throughout the journey of this drug. So that's why some drugs are used as product where it becomes more stable, having better bioavailability. You have already read about the bioavailability. That is the fraction of the drug that reaches the systemic circulation unaltered state. Okay, so this is the definition of the bioavailability. So better bioavailability happens for this product when it is converted to active drug, or other desirable pharmacokinetic properties, or less side effects and toxicity. Again, there may be some drugs, when it is given in the active form, there may be some toxicity. For example, some mucosal irritation may occur when it goes through the intestine. So that may happen. So these all can be curbed when they are given by means of the prodrug. For example, levodopa is converted to dopamine. So levodopa is basically prodrug which does not have action on its own. When levodopa is given in our body by means of the biotransformation, it is converted to dopamine, and this dopamine acts on the different receptors to exert some action. For example, this levodopa is usually used in Parkinsonism. You know about the Parkinson's disease, this levodopa is given. Similarly, enalapril is converted to enalaprilate. Enalapril is an anti-hypertensive drug. So that is when the blood pressure is high, enalapril can be given. So, but enalapril is basically a prodrug. It is converted to enalaprilate, which is the active drug. So this is a product active drug. Similarly, for example, in the hypertensive emergency, that is when there is very high rise of the blood pressure suddenly, this is known as the hypertensive emergency or hypertensive urgency. That's when we need immediate action. Here we can use the enalaprilate instantly by means of the intravenous infusion. So enalaprilate is also available in the market as a formulation, drug formulation, and enalapril is a common tablet form, it is available. So enalaprilate can also be used as such in hypertensive emergency or urgency. You will read about this in the hypertension chapter. Dipivapine is converted to epinephrine. Again, this is used mostly in case of the different types of the eye disease. Prednisone is converted to prednisolone, which is a steroid, oral steroid used in different types of the cases. Becampicillin is converted to ampicillin, it is an antibiotic. So these are the examples of the product converted to the active drug. So product can come as a question, as a short note, and also can be asked in the viva. This is important, okay. So now again, now we are classifying the different biotransformation. Mainly there are two types of the biotransformation, phase 1 reaction and phase 2 reaction. There are two types of the reactions. Phase 1 is also known as the non-synthetic or functionalization reactions. where a functional group is generated or exposed and metabolite may be active or inactive. The metabolite may be active or inactive. Already we have discussed the metabolite may be active, that may be inactive, whatever may be reason. But this is usually the first phase, phase 1. Another is the phase 2 reaction. Usually it comes after phase 1, also known as the synthetic or conjugation reaction. This involves conjugation of the drug or its phase 1 metabolite with an endogenous substrate. That is, the substrate is already present in our body. That's why it is endogenous. So there is some coupling of the substrate with the drug metabolite, usually derived from the carbohydrate or amino acid, to form a polar highly ionized organic acid, which is easily excreted in urine or bile. Normally, usually the phase 1 reaction happens first and then the phase 2 reaction happens. But in some of the drugs, phase 1 reactions never happens, directly phase 2 reaction also happens. So this is the phase 1 and phase 2 reactions. So now coming to the phase 1 reactions, discussion about the non-synthetic or phase 1 reactions. There are different types of the phase 1 reactions. For example, oxidation, reduction, hydrolysis, etc., etc. The most important of this is the oxidation. We'll start with the oxidation. So this reaction involves addition of the oxygen. So oxygen adduct is added, or negatively charged radical, or removal of the hydrogen or positively charged radical. Okay, so this is the oxidation. You know from the chemistry what is oxidation. So oxidation of the drug happens. The most important drug metabolizing reaction is oxidation. Various oxidation reactions are hydroxylation, oxygenation at the carbon, nitrate or S atoms, N or O dealkylation, oxidative deamination, etc. So these are the different chemical changes that happens to the drug. In many cases, the initial insertion of the oxygen atom into the drug molecule produces short-lived, highly reactive quinone or epoxide or superoxide intermediates. So what happens? That within the reactions, there may be some intermediary reactions, and intermediary metabolites are formed. Most of these metabolites contain some free radicals like these quinone radicals, epoxide radical or superoxide radicals, which they then convert to more stable compounds. But these free radicals also causes some oxidative changes. So you perhaps know about the free radicals in the chemistry. So the superoxide free radical is the most common free radical that can occur in our body due to some metabolism of the drugs or other exogenous substance. So these are the intermediary metabolism, and ultimately the total oxidation happens. Now coming to the cytochrome P450. This cytochrome P450 is the main mediator of these oxidation reactions. This is very important, that the cytochrome P450 can come as short note or it can come in the viva. Okay. So the oxidative reactions are mostly carried out by a group of monooxygenases in the liver. So in the liver there are different types of the monooxygenases where these oxidative reactions occur, which in the final step involve a cytochrome P450 hemoprotein. So hemoprotein means there are heme and protein. These two are conglomerated. So heme is basically a structure that contains different types of the molecules, carbon molecules, nitrate molecules, and within this cytochrome P450 hemoprotein is there. Apart from this NADPH, cytochrome P450 reductase is another enzyme that helps this cytochrome P450 formation and molecular oxygen. So these are needed mainly for the oxidation reactions. Now there are more than 100 cytochrome P450 isoenzymes. Isoenzymes means there are subtle changes in the structure of different cytochrome P450 enzymes, and this cytochrome P450 is also present in other mammals or other animals also. In humans, this is also present. Most of the cytochrome P450 from 1 to 4 are usually needed for metabolism of different xenobiotic drugs, and after 5 the different cytochromes are mainly needed for metabolism of endogenous substance. So within our body there are different enzymes and hormones are also there, and they also undergo different cyclical changes. They also undergo metabolism that also needs the cytochrome P450 enzyme. So depending upon the extent of the amino acid sequence homology, these cytochrome P450 isoenzymes are grouped into families designated by numerals. So firstly, cytochrome P450 1, P450 2, 3, like this is present. Now each one or two or three etc. can have several subfamilies that are designated by capital letters A, B, C etc. That is 1A, 1B like this. And again which individual isoenzymes are again allotted numerals like 1A1, 1A2 like this. So there are several isoenzymes. This is known as the isoenzymes of the cytochrome P450. Now in human beings, only a few members of the first three isoenzymes, cytochrome 1, 2 and 3 mostly, up to 4 it can be used, carry out metabolism of the most of the drugs. So remember, usually cytochrome 1 to 3 or 1 to 4 are needed for metabolism of xenobiotic drugs, and after 4 there are some cytochromes are also present, 5, 6 etc. that are needed for metabolism of endogenous substance, not exogenous substance. Okay. So you can see, so this is a cell where the location of the cytochrome P450 is present. You can see this is the endoplasmic reticulum, nucleus, mitochondria, cytoplasm etc. Now if we can broaden this endoplasmic reticulum within the wall of the endoplasmic reticulum, you can see the oxidoreductase cytochrome complex is present. So it is present on the endoplasmic reticulum in the phospholipid bilayer. So basically this is a cell membrane of the endoplasmic reticulum which is a phospholipid bilayer. These cytochrome P450 enzymes are embedded within this phospholipid bilayer, and most of these are present in the cytosolic surface. So outside of the cytosolic surface. So there may be inside of the cell membrane and outside. Outside is known as the cytosolic surface. So within the cytosolic surface this complex is present. Now again it is broadened. So you can see this is mainly the structure. So this is basically a iron protoporphyrin heme and protein combination. This can be broadened again, this structure. So there is one iron, there is 4 nitrogen, and then there is different types of the side chains. So these side chains, you can see the M is the methyl side chain, V is the vinyl side chain, and P is the propionyl side chain. So this is basically a structure of the iron protoporphyrin complex or heme complex. This will be needed in different types of the hemoglobin also. When you will read about the anemia, you will see also this structure. For example, in anemia, you will read about the heme. There are maybe formation of the ferritin, hemosiderin also. There is also this structure is present. So this is known as the iron protoporphyrin 9 or heme structure. This heme structure is present within the cytochrome oxidoreductase complex. So heme structure is basically a iron complex. Iron is combined with 4 nitrogen atoms, and this structure, there are different types of the side chains. The side chains may be vinyl or methyl or propionyl, and this structure is embedded within this cytochrome substrate, and there are NADPH enzyme also. So this is the total structure, and this is the NADPH cytochrome P450 oxidoreductase, which is an enzyme that basically contributes the electron from this heme structure to another. So ultimately this enzyme helps in the formation of this complex. So this complex and the enzyme usually goes side by side. So this is the cytochrome P450 enzyme complex. So it is clear. So it is the site, it is present, cytochrome P450 enzyme is present in the cytosolic site of the phospholipid bilayer of endoplasmic reticulum, and ultimately that contains a iron protoporphyrin heme complex that is combined with some protein, and it is helped by means of the electron transfer from NADPH cytochrome P450 oxidoreductase. So this is about the structure, how the cytochrome P450 is formed. So there are different types of the cytochrome P450. I will discuss about some important ones like cytochrome 3A, 4 or 5. So it comes under family 3, cytochrome P453. Within 3 there is A and then A4 or A5. So they carry out biotransformation of the largest number of drugs. So this is important when we will be asked in the MCQ or any other, what is the most common, that is the most important cytochrome P450 enzyme, that is the cytochrome 3A 4 by 5 usually, 4 or 5 usually. It is expressed in liver, intestine. In the intestine, it is basically responsible for the first pass metabolism, and kidney. inhibition of this isoenzyme by means of the different types of the drugs happens. So there are different drugs that can inhibit or induce this cytochrome P450 enzymes. So what I have said, that the cytochrome basically helps in the oxidation, metabolism of some drugs. And there are some other substrates, there are some other endogenous substances also that are also oxidized by the cytochrome enzymes. And there are the same drug can be oxidized by the same number of the same isoenzyme of the cytochrome P450. So there might be competition of the two drugs. When these two drugs are given which compete for the same isoenzyme, ultimately that leads to either inhibition or induction of one drug over another. So basically this is the basis of the drug interaction. So when there may be some, you will see that this drug should not be combined with this drug. This drug should given after minimum 1 to 2 hours after this drug. This is given by the doctors. So basically this is the main thing, that there may be some drug interactions and there may be some food interactions also. Some food constituents are also metabolized by different oxidation or different cytochromes. So there may be drug-drug interactions or drug-food interactions. তাই জন্য বলা হয় যে খাওয়ার এতক্ষণ আগে খাবেন বা খাওয়ার এতক্ষণ পরে খাবেন বা এই ড্রাগ থেকে এই ড্রাগের এতখানি গ্যাপ রাখতে হয় এই মেটাবলিজমের জন্য মেইনলি। সো ফর এক্সাম্পল এরিথ্রোমাইসিন, ক্ল্যারিথ্রোমাইসিন এগুলো হচ্ছে অ্যান্টিবায়োটিক, কিটোকোনাজল, ইট্রাকোনাজল, দিস আর দ্য অ্যান্টিফাঙ্গালস, they causes inhibition of this isoenzyme cytochrome 3A4/5, and it is responsible for the important drug interactions with terfenadine, astemizole, cisapride. So terfenadine is again another antifungal drug, astemizole similar, cisapride is basically a GI drug, etc. Similarly, losartan, which is an antihypertensive drug, nifedipine, again same, hydrocortisone is a steroid, mifepristone, again it is a hormonal drug, simvastatin that decreases the lipid profile, ritonavir is the antiviral drug, carbamazepine is a CNS drug, helps in the epilepsy, and cyclosporin, it is an immunosuppressive drug. They are also metabolized by the cytochrome P3A4/5. So you have to remember some drugs, for example, when you will write about this cytochrome P450 or cytochrome P3A4, that these metabolize these drugs. Okay. Verapamil, diltiazem, ritonavir. Verapamil is basically calcium channel blocker. It is used as a CVS drug. Diltiazem similar. Ritonavir is an antiviral drug and a constituent of the grapefruit juice. Grapefruit juice is a thing that ultimately causes different types of the food interactions with different drugs, because they are other important inhibitors. They inhibit this enzyme, while rifampicin, barbiturate and other anticonvulsant are the important inducer. So some drugs induce this enzyme, some drugs inhibit the enzyme. So that can increase or decrease the metabolism of some other drugs, that ultimately leads to either subtherapeutic effect, that is the effect will not happen at all, or toxicity of the drug. So this can happen due to drug interactions. Next important is the cytochrome 2D6. So this is the 3A4/5. Next is the 2D6. Is the next most important cytochrome P450 isoform that metabolizes nearly 20% of the drugs. That includes tricyclic antidepressant like imipramine, amitriptyline, etc. Selective serotonin reuptake inhibitor like escitalopram, etc. These are the CNS drugs, central nervous system drugs. Many neuroleptics, antiarrhythmics, that is used in the cardiac arrhythmia. Beta blockers, you read about the beta blockers that is used in various diseases, and opiates. So these cytochrome P450 2D6 is responsible for the metabolism of these drugs. Okay, so inhibition of this enzyme by quinidine. So quinidine is a drug that can inhibit this 2D6, results in failure of conversion of codeine to morphine. So codeine cannot be converted to morphine, so analgesic effect of the codeine is lost. So codeine, you can see that codeine is present, codeine is used in as a pain relieving substance in many of the cases, in many cancer also. See, this codeine is basically converted to morphine. So morphine is the active part. So morphine conversion cannot occur when this quinidine is given. This quinidine blocks the cytochrome P2D6 and ultimately this conversion does not happen. So analgesic effect does not occur. So this is an example. Human subjects can be grouped into extensive or poor metabolizer of the metoprolol or debris-queen. Metoprolol is a very common drug used as an antihypertensive or ischemic heart disease. So there may be some man-to-man variation about these different enzymes. So some enzymes in one human being can metabolize the same drug very fast or very rapidly, and in another very slowly. So that's why this can be grouped as the extensive metabolizer or poor metabolizer. The poor metabolizer have an altered cytochrome P2D6 enzyme and exhibit low capacity to hydroxylate many drugs. That's why the same drug, this selective serotonin reuptake inhibitor, is used as a many in case of the anti-anxiety drug or antidepressant drug. So in some of the cases that may ultimately lead to toxicity. This tricyclic antidepressants also, because the metabolizing enzymes in those humans are very slow. That's why there may be more toxic concentrations are achieved in those persons in comparison to other persons where the metabolizing enzyme is normal and they are metabolize the enzyme very rapidly. So in the same drug, in the same situation, in one human being can lead to toxicity, and the another human being there may be no toxicity. So this is the basis. The poor metabolism already because there is low capacity to hydroxylate, because the hydroxylation, the oxidation, these are needed to render it non-toxic. That's why. Cytochrome P2C8/9 is important in the biotransformation of greater than 15 commonly used drugs, which like phenytoin, it is an anti-epileptic drug, carbamazepine, same anti-epileptic, warfarin is an anticoagulant drug. These are narrow safety margin drugs. Narrow safety margin already you have read. So the safety margin is narrow. So even if the plasma concentration becomes slightly high, that becomes toxic, or slightly low, that becomes sub-therapeutic. That is, no effect will be seen. So that's why this is important. So if there is some interactions with this enzyme, there may be toxicity with this. So that's why we should be cautious when using these drugs, that which are the other drugs that can induce or inhibit this enzyme. Okay. So 2C19 is another that metabolizes greater than 12 frequently used drugs like omeprazole, very common. It is a proton pump inhibitor. Dyspepsia or peptic ulcer use kora hai, lansoprazole, same, phenytoin, diazepam, propranolol, etc. So you can see phenytoin, like there are several drugs that can be metabolized by more than one enzymes. So phenytoin can be metabolized by the cytochrome P2C19 as well as the cytochrome P2C8/9. Now this rifampicin and carbamazepine, these are the potent inducer of this cytochrome P2C subfamily. That is all these, whether it is 2C8 or 9 or 2C19, all these are potently induced by rifampicin and carbamazepine. So rifampicin is basically an antibacterial drug that is most commonly used as an anti-tubercular drug, anti-tubercular or anti-leprotic drug. Tuberculosis or leprosy use kora hoy. Carbamazepine hoche arekta anti-epileptic drug. So when these two drugs are combined, for example, the patient is already taking warfarin and also rifampicin without a minimum gap, so there may be interactions of the drug and there may be chances of the toxicity or subtherapeutic concentration. Okay. And omeprazole is an inhibitor of the cytochrome P2C family. So rifampicin, carbamazepine are the enzyme inducer and omeprazole is an enzyme inhibitor. Okay. Another is the 1A1/2 that participates in the metabolism only of some drugs like theophylline, caffeine, paracetamol, carbamazepine. It is more important for activation of the procarcinogens. So basically there are some substances that can induce cancer. So these are known as the procarcinogens. This cytochrome 1A1/2 is usually used for activation of these procarcinogens. So apart from rifampicin and carbamazepine, polycyclic hydrocarbons, cigarette smoke, within the smoke this polycyclic hydrocarbon is also present, and charcoal broiled meat are also potent inducer of different enzymes. So when you are asked about some examples of the enzyme inducers, cytochrome P450 inducers, the most common, remember, rifampicin. Rifampicin is the most common inducer and that can also cause drug interactions. Next is the carbamazepine is also most common inducer that can induce a myriad cytochrome P450 family. Apart from this, cigarette smoke, polycyclic hydrocarbon, charcoal broiled meat are also inducer. And most common inhibitor is the omeprazole. So omeprazole is the enzyme inhibitor. Another is cytochrome P2U1 that catalyzes oxidation of the alcohol. Halothane. Halothane is an anesthetic drug. formation of the minor metabolites of the few drugs, notably from the paracetamol, there is a metabolite is formed known as the N-acetyl benzyl quinonimine. So you will read about in the NSAIDs chapter. This is important because in paracetamol toxicity, when paracetamol is given in large doses, that leads to toxicity, and this toxicity occurs due to this metabolite N-acetyl benzoquinonimine, which is basically a hepatotoxic that ultimately causes liver failure, and in very high paracetamol overdose, liver transplant is also needed. So that is caused due to this hepatotoxic metabolite, and this changes, biotransformation happens due to this cytochrome P2E1 isoenzymes. Chronic alcoholism also induces this isoenzyme. So chronic alcoholics jara royeche, this induction of this cytochrome P450 happens. Next, after, so oxidation is the most important. Within the oxidation, cytochrome P450 enzyme is very important for your exams also. Next, coming to the reduction, it is the converse of the oxidation involves cytochrome P450 enzymes working in the opposite direction. That is, reduction is opposite of oxidation. Usually alcohol, aldehyde, quinones, these are reduced. Drugs primarily reduced are the chloral hydrate, chloramphenicol, halothane, warfarin, etc. Warfarin is an anticoagulant, already you have seen. Halothane is a general anesthetic. Chloramphenicol, chloral hydrate, these are lesser used now. Okay. So after oxidation and reduction, next is the hydrolysis. Hydrolysis is the cleavage of the drug molecules by taking up a molecule of water. Hydrolysis, just a molecule of water is added. So ester, usually the drugs, plus H2O by means of the enzyme esterase, it is converted to acid plus alcohol, which is usually water soluble. Similarly, amides and polypeptides are hydrolyzed by amidases and peptidases. So these are the different enzymes are present. There are epoxide hydrolyses are also present, which detoxified epoxide metabolite of some drugs generated by cytochrome oxygenase. So cytochrome oxygenase এর সাহায্যে আবার চেঞ্জ হয়ে আবার বিভিন্ন রকম মেটাবোলাইট তৈরি হয়. One is such is the epoxide metabolite that can also be detoxified by means of the epoxide hydrolase, which is basically a hydrolysis, which causes hydrolysis. This hydrolysis also occurs in the liver, intestine, plasma and tissues. Examples of hydrolysis are drugs like cholinesterase, procaine, lidocaine. These are the local anesthetic, procainamide, antiarrhythmic drug, aspirin used as a NSAIDs as well as a low antiplatelet drug, carbamazepine epoxide, pethidine, oxytocin, etc. Oxytocin is a hormonal drug. Pethidine is used as analgesic. Carbamazepine epoxide, carbamazepine is used as a CNS drug, etc. So this is hydrolysis. There are some other minor phase 1 reactions like cyclization, that is cycle is added, formation of a ring structure from a straight chain compounds. Ekta ring structure hoye jacche straight chain theke. Example is the proguanil, this is used as a antimalarial drug. Decyclization, just opposite, that is the ring structure is already present in the drug, it is opening up the ring structure. Example is barbiturate phenytoin, this is generally a minor pathway. Few drugs like cimetidine, ranitidine, clozapine, etc. are oxidized in other sites like N, P or S atoms by a group of flavin monooxygenases that are also located at hepatic endoplasmic reticulum but are distinct for cytochrome enzymes. That is, it is not such that all oxidation occurs due to the cytochrome P450 enzymes. There may be some flavin monooxygenases that are also present in the same site like that of the cytochrome P450, and that usually metabolize the ranitidine, clozapine, etc. Clozapine is again this is basically an antipsychotic drug. Ranitidine is used, you know about this, that is used in the peptic ulcer or dyspepsia. Now they are not susceptible to induction and inhibition by other drugs, these drugs, and thus are not involved in drug interactions. That is, drug interactions usually happens when these drugs are metabolized by cytochrome P450 enzymes. But when the drug is metabolized by other enzymes like other flavin monooxygenases, the drug interactions are very less. Some other drugs like adrenaline, alcohol, mercaptopurine, etc. are oxidized by mitochondrial or cytoplasmic enzymes, that is other enzymes. Okay. So after the phase 1, next coming to the phase 2 reaction or synthetic reactions. So within the phase 2, the most important is the glucuronide conjugation or glucuronidation. This is also important for your exam. So most important synthetic reaction carried out by a group of UDP-glucuronosyltransferases. So in the phase 1, oxidation is the most important. In the phase 2, glucuronide conjugation is the most important. And it is done by the UDP-glucuronosyltransferase enzyme. Compounds with a hydroxyl or carboxylic acid groups are conjugated with glucuronic acid derived from glucose. So this glucuronic acid is derived from glucose, and these compounds, that is the drugs which have a hydroxyl or carboxylic acid group, either it is de novo present or it is metabolized by means of the phase 1 reactions. They are combined, conjugated with this. Examples are the chloramphenicol, this is an antibiotic, aspirin, paracetamol, diazepam, lorazepam, this is a CNS drug, morphine, metronidazole, this is used in anaerobic infections. So these are the drugs that are metabolized by glucuronide conjugation. Not only drugs but endogenous substance, endogenous, that is already present in our body, like bilirubin, steroidal hormones, thyroxine, they also utilize this glucuronide conjugation pathway. Glucuronidation increases the molecular weight of the drug, which favors its excretion in bile. So when this glucuronidation occurs, it is usually excreted through bile, and drug glucuronides excreted in bile can be hydrolyzed by bacteria in the gut. Through the bile, it comes to the intestine. Within intestine, there are different beneficial bacteria. These bacteria hydrolyze this conjugate products. The liberated drug is reabsorbed. Some part of it is reabsorbed, and some undergoes the same fate. Okay. Next, coming to the acetylation. Compounds having amino or hydrazine residues are conjugated with the help of acetyl coenzyme A. Example are sulfonamides. Sulfonamides antibiotic, isoniazide, it is used as an anti-tubercular drug. PAS, para-aminosalicylic acid, again it is used as anti-tubercular drug. Dapsone, it is used as an anti-leprotic drug. Hydralazine, it is a CVS drug. Clonazepam, clonazepam is like lorazepam, etc. This is a CNS drug. Procainamide, this is used as antiarrhythmic drug. So they are acetylated. Multiple genes control the N-acetyltransferase. This N-acetyltransferase is the main enzyme that causes the acetylation, and the rate of acetylation shows genetic polymorphism. This is also important. So there may be some fast acetylator or slow acetylators. You will read about this in the warfarin chapter, in the anticoagulant. Because this warfarin may be drug interaction may occur with these other drugs that causes acetylation, and some persons are fast acetylator, some are slow acetylator. So accordingly, the metabolism of the drug varies between person to person. So slow acetylator, fast acetylator can happen. Next is glutathione conjugation. The first one is the glucuronide conjugation. This is the glutathione conjugation. This is carried out by glutathione S-transferase enzyme. Okay, glutathione S-transferase, that forming a marcapturate. So marcapturate is formed. It serves to inactivate highly reactive quinone or epoxide intermediates formed during metabolism of certain drugs like paracetamol. So what happens when paracetamol is metabolized? There are highly reactive superoxide or epoxide intermediates are formed. They are basically rendered non-toxic by means of this glutathione conjugation. You will read about the paracetamol chapter that when there is paracetamol overdose, there are depletion of this glutathione. This glutathione depletion occurs from the liver. So the glutathione are less to render the more amount of the paracetamol non-toxic. So ultimately the paracetamol intermediate, already we have seen, the toxic intermediate causes some hepatotoxicity. So ultimately liver failure can happen. So the same thing, when large amounts of the such intermediates are formed in poisoning or after enzyme induction, glutathione supply falls short. That is, glutathione depletion occurs. Toxic adducts are formed with tissue constituents and tissue damage happens. That is, when the paracetamol is given, the paracetamol intermediates are very much toxic. They undergo different types of the metabolism. One of the important is the glutathione conjugation. This glutathione is present in the liver and they contain the SH group. So glutathione means sulfhydryl group, SH. So when this paracetamol metabolite comes, this sulfhydryl group forms adduct, that is conjugated with this, and ultimately it becomes non-toxic. So when the paracetamol poisoning happens, or we are giving some other drugs that induce this, that is more paracetamol intermediates are available in the liver, So the already present glutathione cannot contain all the toxic materials of the paracetamol. So there occurs, this is known as the glutathione depletion. The glutathione falls short of the paracetamol to make it non-toxic. So ultimately the toxic compound causes the liver damage. So this is the basis of the paracetamol overdose, paracetamol poisoning. So paracetamol poisoning is intrinsically linked to glutathione conjugation. This is again comes when you will read about the paracetamol. So there are other conjugations like methylation, sulfate conjugation, ribonucleoside or nucleotide synthesis. Basically these are amines and phenols methylated, example adrenaline, histamine, nicotinic acid, methyl dopa, etc. Here the phenolic compounds and steroids are sulfated, so sulfate conjugated. Just remember the example chloramphenicol, methyl dopa, etc. And this is the nucleotide or nucleoside synthesis, important for mainly many purine or pyrimidine antimetabolites. Mainly it is used in cancer chemotherapy. So different drugs that are used in cancer chemotherapy can be metabolized by these. So you can see what I am telling, that there may be simultaneous or sequential metabolism of the drugs. So this is the drug. Drug means a xenobiotic that can go to the phase 1, the metabolite is formed, that metabolite may be excreted. In some drugs, that metabolite again undergo the phase 2 and then another metabolite form that may be excreted. Again, there are some drugs that will not go to the phase 1 at all, they directly goes to the phase 2 and phase 2 metabolites are formed, again it is excreted. So there are different pathways for the different drugs. So this is known as the simultaneous. So simultaneously phase 1 or phase 2 reactions can happen, or sequential phase 1 and then phase 2 metabolism of a drug by phase 1 and phase 2 reactions. So this is the basis. So this drug metabolism, most drugs are metabolized are many pathways simultaneously or sequentially. Already you have seen rates of the reaction by different pathways often vary considerably. Already I have seen person to person variation in there. Some are fast acetylator, some are slow acetylator, for example. A variety of metabolites are formed. Stereoisomers of a drug may be metabolized differently. Stereoisomers, you have read in chemistry, there may be S isomer, there may be R isomer, etc. Warfarin is a anticoagulant, oral anticoagulant that have S isomer and R isomer. But the S isomer rapidly undergoes ring oxidation, the R isomer is slowly degraded by side chain reduction. That is the same drug, different isomers undergo different types of the metabolism. Only a few drugs are metabolized by enzymes of intermediary metabolism. Intermediary metabolism, some drugs are there, like alcohol by dehydrogenase, allopurinol by xanthine oxidase. There may be intermediary metabolism or there may be different steps of the metabolism may happen for some drugs. So these are the enzymes. There are different enzymes already we have read. So ultimately we are classifying these enzymes now. So majority of the drugs are acted on by relatively non-specific enzymes which are directed to types of molecules rather than to specific drugs. So this is not specific for individual drug. The same type of the enzyme can metabolize different types of the drugs. So these drug metabolizing enzymes can be divided into either microsomal or non-microsomal. Microsomal enzymes are located on the smooth endoplasmic reticulum, primarily in the liver, kidney, intestinal mucosal links and the lungs. And this cytochrome P450 enzyme ultimately belongs to this microsomal enzyme. Okay. So cytochrome P450 ultimately is a microsomal enzyme. Apart from cytochrome P450, there may be some monooxygenase like flavin monooxygenase, already we have seen. UGTs, that is the glucuronide conjugation occurs, epoxide hydrolysis, etc. These are all microsomal enzymes. So this comes under the microsomal enzymes. They catalyze most of the oxidation, reduction, hydrolysis and glucuronide conjugation. So now we are classifying these enzymes irrespective of the phases. Either it is phase 1 or phase 2. For example, you can see microsomal enzymes can be instrumental in both phase 1 and phase 2. In the phase 1, they can carry out oxidation, reduction, hydrolysis. In the phase 2, they can carry out glucuronide conjugation. The most important is that is the UGTs. That is the cytochrome P450, different other flavin monooxygenases, UGTs that is involved in the glucuronide conjugation, all comes under microsomal enzymes. Okay. Microsomal enzymes are inducible by drugs, diets and other agencies. That is, these microsomal enzymes, already we have read about the cytochrome P450 elaborately. So they are basically involved in drug-drug interactions, drug-food interactions, what I have discussed beforehand. So all these are microsomal enzymes. Non-microsomal enzymes are present in the cytoplasm or mitochondria of the hepatic cell as well as in other tissues including plasma. So already most of the cases, most of the drugs are usually metabolized by the microsomal enzymes, but there are some drugs that can be metabolized by non-microsomal enzymes also. Non-microsomal, that is, it is not present in the microsome, that is present in the cytoplasm, present in the mitochondria, present in the plasma, anywhere else. Esterase, amidases, some flavoprotein oxidase, and most conjugases are non-microsomal. So these are the other enzymes that are utilized in both phase 1 and phase 2 reactions that comes under the non-microsomal enzymes. Reactions catalyzed us, there are some oxidation and reduction that are catalyzed by these, many hydrolytic reactions, and all conjugation reaction except the glucuronide conjugation, glucuronidation. Glucuronide conjugation is caused by the microsomal enzyme. But all other conjugation, whether it is sulfate conjugation, acetylated conjugation, etc., all are basically catalyzed by the non-microsomal enzyme. The non-microsomal enzymes are not inducible, but many show genetic polymorphism. Already again we have discussed, like acetyltransferase, there may be slow acetylator, fast acetylator, pseudocholinesterase, this is another thing, you will read about the ANS chapter. So this slow, fast, etc., this basically happens in the non-microsomal enzymes. Okay. Both microsomal and non-microsomal enzymes are deficient in the newborn. So there are variation in the newborns and also in the old age also. In the newborn, there are deficiency of these enzymes, especially premature babies like chloramphenicol, opioids, etc. cannot be metabolized by these. So this deficit is made up in the first few months of life, more quickly in case of the oxidation and other phase 1 reactions than in case of the glucuronide and other conjugations, which take usually 3 to 4 months. That's why many drugs cannot be given in the newborn or in the first 3 months to 6 months in life of a newborn, because these drugs will not be metabolized at all, because these enzymes are not developed in the newborn. That's why. The amount and kind of drug metabolizing enzyme is controlled genetically and is also altered by the environmental factors. So genetics also play a pivotal role in controlling all these enzymes. Thus, marked interspecies and inter-individual differences are there. One of the major causes of the individual variation in drug response. Time and again I am discussing. So individual variation in the drug response, one-to-one variation. All this happens due to the difference in the drug metabolizing enzymes, how they take control of the different drugs to make it non-toxic. Another thing is the Hofmann elimination. This is another metabolism. This refers to the inactivation of the drug in the body fluids by spontaneous molecular rearrangement without the agency of any enzyme. So there is no enzyme is involved. There is spontaneous molecular rearrangement happens. So ultimately the drug becomes non-toxic and more water soluble. Example is the atracurium. Atracurium is again an anesthetic drug. Atracurium basically is a muscle relaxant. So remember, this can come as a short note or it can be asked in the MCQ or Viva. So Hofmann elimination occurs in the atracurium where no enzyme is needed for its metabolism. Only molecular rearrangement on its own happens. Okay. So this is in a nutshell, you can see xenobiotic metabolizing enzymes. There are some enzymes and some reactions. This is just example. For example, we have detailedly discussed the cytochrome P450. This is very important for your cytochrome P450. C and O oxidation, dealkylation, others can happen. Flavin containing monooxygenases, NS and P oxidation can happen. Epoxide hydrolase can cause hydrolysis of the epoxide. Within the phase 2 transferase, the most important is the UGT, that is the UDP-glucuronosyltransferase, that causes addition of the glucuronic acid. Sulfotransferase, that causes addition of the sulfate. Glutathione S-transferase, that causes the addition of the glutathione. This is important. Already I have discussed about the paracetamol overdose. This glutathione addition is needed for protection from the liver. N-acetyltransferase is addition of the acetyl group. Here the slow acetylator, fast acetylator can occur, and this is important for warfarin. Methyl transferase causes addition of the methyl group. So this is the different enzymes in the phase 2. There are other enzymes like alcohol dehydrogenase that causes reduction of the alcohol. Aldehyde dehydrogenase causes reduction of the aldehyde, and NADPH quinone oxidoreductase that causes reduction of the quinone. So in a nutshell, you can see that different types of the enzymes that are instrumental in the phase 1 or phase 2 reactions. So coming to the inhibition of the drug metabolism. So one drug can competitively inhibit the metabolism of another if it utilizes the same enzyme or cofactors. Already we have discussed. So this is the basis. The same enzyme is utilized. That's why drug inhibition can occur. Drugs may inhibit one enzyme, isoenzyme, while being itself a substrate of another isoenzyme. Like quinidine is basically metabolized by cytochrome P3A4, but it inhibits cytochrome P2D6. That is, it is metabolized by one thing, but it can inhibit other thing, other isoenzyme. It can happen. Clinically significant inhibition of the drug metabolism occurs specially if they are metabolized by saturation kinetics or if kinetics changes from first order to zero order over the therapeutic range. You have already read about the first order kinetics, zero order kinetics. It's a very important for your exam. So clinically significant inhibition of the drug usually happens for these drugs which usually follows the zero order kinetics or which changes their kinetics from first order to zero order. And inhibition of the drug metabolism occurs in a dose related manner. That is, with increased dose there will be increased inhibition and can precipitate toxicity of the object drug, that is the whose metabolism has been inhibited. Okay. Because enzyme inhibition occurs by direct effects on the enzyme, it has a fast time course. That is, it occurs very fast, and metabolism of the drugs with high hepatic extraction is dependent on liver blood flow. How the amount of the blood flowing to the liver also determines how the hepatic extraction of the drug happens. Example, propranolol, which is a beta blocker, reduces the rate of lidocaine metabolism by decreasing the hepatic blood flow. So it decreases the hepatic blood flow, so ultimately its metabolism also decreases. Some other drugs whose rate of metabolism is limited by hepatic blood flow, examples are morphine, propranolol, verapamil, imipramine. So remember, say they basically causes the drug interactions by decreasing the hepatic blood flow by a unique mechanism. Morphine, propranolol, verapamil and imipramine, this causes this. Okay. So drugs that inhibit the drug metabolizing enzymes, these are just examples, just go through it. So different types of the drugs that inhibit the drug metabolizing enzymes. Next, coming to the microsomal enzyme induction, just opposite of the inhibition. So insecticide, carcinogens, they interact with DNA and increase the synthesis of these enzyme proteins, especially the cytochrome P450 and UGTs. So as a result, the metabolism of the inducing drug itself or other drugs is increased. So there are different anti-convulsant drugs like phenobarbital, phenytoin, carbamazepine, rifampicin, glucocorticoids, etc. They can induce the cytochrome 3A isoenzymes. So these are the examples of the induction of the drug, induction of the isoenzymes. Phenobarbital also induces the cytochrome P2B1 and rifampicin also induces 2D6. Rifampicin is a very common enzyme inducing drug, already I have said, and omeprazole is an enzyme inhibitor drug, very common. Isoniazid and chronic alcohol consumption also induces the cytochrome P2E1 and polycyclic hydrocarbons. There are different polycyclic hydrocarbons are present in the cigarette smoke or charcoal broiled meat. Omeprazole, industrial pollutants, etc. also induce the cytochrome 1A in isoenzyme. So omeprazole can inhibit the 2D6, the C family, but they can also induce the cytochrome P1A family. So this is another example. There are various examples, that is the same drug can induce one enzyme, can inhibit another enzyme. So there are other enzyme inducers are phenylbutazone, griseofulvin, DDT, etc. These are the examples. Phenobarbital, like inducers of the 3A and 2D6, affect the metabolism of a large number of drugs because these isoenzymes act on many drugs. So phenobarbital, rifampicin, remember these two are very common enzyme inducers. Induction of the polycyclic hydrocarbon is limited to theophylline, phenacetin, etc. Because cytochrome 1A1 isoenzyme metabolizes only few drugs. These are all are examples. Induction involves microsomal enzymes in liver as well as other organs and usually increases the rate of metabolism by 2 to 4. That is, the rate of metabolism increases. Induction takes usually 4 to 14 days. It usually takes time rather than inhibition and is maintained till the inducing agent is being given. Thereafter, the enzyme returns to their original value over 1 to 3 weeks. So inhibition occurs rapidly, induction happens slowly. So if there is enzyme induction rapidly happens, ultimately that causes ineffective drug. That is another drug that becomes more metabolized. So lesser concentration is available for action. So that becomes subtherapeutic concentration that do not action at all. So enzyme induction, this is the problem. So consequences of the microsomal enzyme induction: decreased intensity or duration of action of the drugs that are inactivated by metabolism, like failure of contraceptive with oral contraceptives. Like when the oral contraceptive is given and again the rifampicin is given for antitubercular drug, the oral contraceptive cannot act at all. So pregnancy can happen. So this is the example of the pitfalls of the enzyme induction. Increased intensity of the action of the drugs that are activated by metabolism, like acute paracetamol toxicity due to one of its metabolite. Toxicity occurs at low doses in patients receiving enzyme inducer. Again, the paracetamol toxicity can happen if there is more metabolism, if there is enzyme induction, because the paracetamol metabolite itself is very much toxic. So if there is more toxic metabolite is formed, there may be more toxicity. Tolerance can happen if the drug induces its own metabolism, like carbamazepine, rifampicin. If the tolerance happens, again the action will be diminished. Some endogenous substances like steroid bilirubin are also metabolized faster. So ultimately, precipitation of the acute intermittent porphyria can happen. So this is a disease. So precipitation can happen due to this enzyme induction. Intermittent use of an inducer may interfere with adjustment of dose of another drug. কি করে অ্যাডজাস্ট করব সেটা করা যায় না, যেমন ওরাল অ্যান্টিকোয়াগুলেন্ট, ওরাল হাইপোগ্লাইসেমিক, অ্যান্টিএপিলেপটিক এটসেট্রা। ইন্টারফেয়ারেন্স উইথ ক্রনিক টক্সিসিটি টেস্টিং ইন অ্যানিম্যালে একটা ড্রাগ আসার আগে ক্রনিক টক্সিসিটি টেস্টিং করা হয়, সেটা ইন্টারফেয়ারেন্স হয়। ড্রাগস হুজ মেটাবলিজম ইজ সিগনিফিক্যান্টলি অ্যাফেক্টেড বাই এনজাইম ইন্ডাকশন আর phenytoin, warfarin, tolbutamide, etc. So there are different drugs that are significantly affected by this. So possible use of the enzyme induction: congenital non-hemolytic jaundice. It is due to the deficient glucuronidation of bilirubin. Phenobarbital hastens clearance of the jaundice. So it can be used here. Cushing syndrome: phenytoin may reduce the manifestations by enhancing degradation of adrenal steroids which are produced in excess. Chronic poisonings by faster metabolism of the accumulated poisonous substance and liver disease. So these are the used, because this inhibition or induction also used for treatment of the other disease, because we need immediate treatment or we need more the poisonous substance to be removed. That's why. Lastly, coming to the first pass of pre-systemic metabolism, you have read something about this in the bioavailability. So metabolism of a drug during its passage from the site of absorption into the systemic circulation. First pass metabolism, and this basically happens due to this metabolism. Or orally administered drugs are exposed to the drug metabolizing enzyme in the intestinal wall and liver, and this can be avoided by administering the drug to the sublingual, transdermal or parenteral route. আমরা যদি ফার্স্ট পাস মেটাবলিজম অ্যাভয়েড করতে যাই, আমরা সাবলিঙ্গুয়াল রুটে দিতে পারি, ট্রান্সডার্মাল রুটে ড্রাগ দিতে পারি, or আমরা parenteral রুটে দিতে পারি, মানে intravenous or intramuscular. Already you have read about this. So by this way the first pass metabolism can be avoided, কারণ একটা ড্রাগ যখনই ওরালি দেওয়া হবে তখনই সেটা ওই ইন্টেস্টাইন দিয়ে যাবে, লিভার দিয়ে যাবে, মাইক্রোজোমাল এনজাইম দিয়ে মেটাবোলাইজড হবে এবং আলটিমেটলি ফার্স্ট পাস মেটাবলিজম হবে। However, limited pre-systemic metabolism can occur in the skin. ট্রান্সডার্মালের ক্ষেত্রেও কিন্তু খুব সামান্য হলেও ট্রান্সডার্মাল একটুখানি মেটাবলিজম হয়, and in lungs for drugs reaching venous blood through any route or transdermally administered drug. মানে অন্য রুট দিয়ে দিলেও কিন্তু সামান্য পরিমাণে হয়, কিন্তু তার রেটটা কিন্তু খুবই কমে যায়। The extent of the first pass metabolism differs for different drugs and is an important determinant of the oral bioavailability. Oral bioavailability যখন তোরা লিখবি তখনই কিন্তু ফার্স্ট পাস মেটাবলিজমটা একটা ইম্পর্টেন্ট, সেই জিনিসটা বলতে হবে। So these are the extent of the first pass metabolism. For example, this can be low, this can be intermediate or high. অনেক বেশি ফার্স্ট পাস মেটাবলিজম হচ্ছে। লো হচ্ছে ফেনোবারবিটন, ফিনাইলবিউটাজোন এক্সাম্পল। ইন্টারমিডিয়েট এক্সাম্পল হচ্ছে অ্যাসপিরিন, কুইনিডিন, নর্ট্রিপটিলিন। এবার হাই হচ্ছে নট গিভেন ওরালি দিচ্ছি না, তার ফলেও হাই ফার্স্ট পাস মেটাবলিজম হচ্ছে আইসোপ্রেনালিন, লিডোকেইন, হাইড্রোকর্টিজনের ক্ষেত্রে। আর ওরালের ক্ষেত্রে ভেরি হাই ফার্স্ট পাস মেটাবলিজম হচ্ছে প্রোপ্রানোলল, ভেরাপামিল, স্যালবুটামল, মরফিন, পেথিডিন এগুলোর ক্ষেত্রে। So these are the different extent. So extent of the first pass metabolism varies between one drug to another drug. So lastly, the attributes of the drugs with high first pass metabolism. কোন ড্রাগের হাই ফার্স্ট পাস মেটাবলিজম হচ্ছে? ওরাল ডোজ ইজ কনসিডারেবলি হায়ার দ্যান সাবলিঙ্গুয়াল আর প্যারেন্টারাল ডোজ। অনেক বেশি ওরাল ডোজ লাগছে, যার ফলে there is marked individual variation in the oral dose due to differences in the extent of the first pass metabolism. এর ফলে ইন্ডিভিজুয়াল ভ্যারিয়েশন কিন্তু অনেকটা হয়, মানে একই ডোজে একজনের কাজও আরেকজনের হয় না, অনেক বেশি ডোজ দিতে হয়, কারণ আরেকজনের ফাস্ট পাস মেটাবলিজমটা অনেক বেশি। ওরাল বায়োঅ্যাভেলেবিলিটি ইজ অ্যাপারেন্টলি ইনক্রিজড ইন পেশেন্টস উইথ সিভিয়ার লিভার ডিজিজ। সিভিয়ার লিভার ডিজিজের ক্ষেত্রে ওরাল বায়োঅ্যাভেলেবিলিটি কিন্তু অনেকটা বেড়ে যায়, মানে ড্রাগ অনেক বেশি অ্যাভেলেবেল হয় এবং আলটিমেটলি টক্সিসিটি হওয়ার সম্ভাবনাও কিন্তু অনেকটা বেড়ে যায়। Oral bioavailability of a drug is increased if another drug competing with it in first pass metabolism is given concurrently. যদি একসঙ্গে দেওয়া হয় সেক্ষেত্রেও হতে পারে। Example, chlorpromazine and propranolol. The same thing, time and again already we have discussed. So you can see in a nutshell, so what are the different drugs? So most of the drugs you can see are metabolized by the cytochrome P3A4/5. The same thing, time and again these are important. In the phase 1, in the phase 2 glucuronide conjugation, UGTs. So these are the other enzymes that are involved in the phase 1 reactions. These are the other enzymes that are used in the phase 2 reactions. So this is the pie chart. So lastly, to conclude, this is the summary. Phase 1 reactions involve oxidation, reduction, hydrolysis, etc. They usually form more chemically reactive products which can be pharmacologically active, toxic or carcinogenic, often involve a monooxygenous system in which the most important is the cytochrome P450. Phase 2 reactions involve mainly conjugation. The most important is the glucuronidation or glucuronide conjugation of a reactive group, often inserted during phase 1 reactions and usually lead to inactive or polar products that are readily excreted. Some conjugated products are excreted via bile, are reactivated in the intestine and again reabsorbed. This is known as the enterohepatic circulation. Again reabsorbed, some part again reabsorbed. This is known as the enterohepatic circulation. Induction of the P450 enzymes can greatly accelerate hepatic drug metabolism. It can increase the toxicity of the drugs with toxic metabolite. And pre-systemic metabolism in the liver or gut wall, pre-systemic means first pass metabolism, reduces the bioavailability of several drugs when they are administered by mouth. So these are the nutshells of all my class.